All right. Hello, everybody. Good morning. It's my great pleasure to be a part of our third annual Cardiology Grand Round Speaker Series, sponsored by the BIDMC Women's Cardiovascular Leadership Development Group. And really, by way of introduction, from my perspective, the seeds of our interest group really were planted, like many things in the division, about 15 years ago by Mark Josephson and Dwayne Pinto. My fellowship class in 2007 was actually the first class in the history of our fellowship in which 5 of the 8 first-year fellows were women, which is really unprecedented at that time and really nationally. And the following year, 4 outstanding females, Anne-Marie and Agnostopoulos, Megan York, and Riley and Connie Sau, joined our program. And over 10 years later, we're still fortunate to have them on our team taking care of patients and actively mentoring residents and fellows. And initially, much of our extracurricular focus was really on public awareness of heart disease in women. And for that, we presented to lay people at locally sponsored events, sometimes by the American Heart Association, including the Go Red for Women campaign under Lauren Feinberg's guidance. And then we also worked closely with the medical leadership at BIDMC to speak at philanthropic events in an effort to raise awareness and the need for funding of women's cardiovascular health issues. And kind of fast forward now, like to 2018, and after a few years of talking to female residents who were kind of reconciling their intellectual interest in cardiology with their concerns regarding kind of what work-life balance might look like in a subspecialty that's really only 15% women, yet in an era in which half of all medical students are women. Anne and Megan, along with then resident Inbar Raber, took it upon themselves to put together a group of us to kind of blue sky what we thought it might look like for us to recruit, nurture, and retain outstanding female fellows and faculty here at BI. And fortunately, the timing was right. Rob had just started as division chief, Peter was continuing in his role as associate chief, and Joe was heading up the fellowship. And all three have been incredibly supportive of our efforts and have been really instrumental in our success. It's amazing. We now have women on faculty in every subspecialty within cardiology, with Marie France in interventional, Patty in EP, we've got Francine in lipid clinic, and Marwa Shweta, Lisa and Arthi in heart failure. And with our resident fellowship mentoring program, our biannual lunch speaker series, and quarterly social gatherings, we've really become a nationally recognized template by the ACC on how to put together a women's cardiology leadership group. And I think in my mind, it's a bit funny to me because even as a woman, I think I have on occasion kind of questioned the need for such a women's group in 2021. But just last week, I had a first-year medical student pull me aside and say, you know, I really thought I wanted to be a psychiatrist, but I'm finding cardiology really interesting. It's not really something I ever thought I could actually do as a career, but I see you doing it, and it makes me think that maybe I could do it too. And I think it kind of struck me, you know, if a first-year medical student at Harvard who should know that anything in the world is possible for her question, you know, for her to question what her career options could be, that's just a reminder to me that we have much that remains to be done by each and every one of us in trying to recruit more women into cardiology. And as everyone knows, the pandemic has really made divisional visibility difficult for working parents, which means that many of the workplace triumphs we've made, particularly by women, may be lost in the shuffle. And I think kind of in closing, my challenge to each of you this coming year is just to keep your female colleagues at the forefront of your minds when new interesting opportunities present themselves, whether it be for, you know, hospital-wide committees, teaching or leadership positions at HMS, serving on ACC or AHA kind of guideline review panels, or engaging in interesting research projects. I think it's always easy to take the path of least resistance. I do it myself, and talk to whomever's office is closest to yours, or the person you did take next to in clinic, or with whom you like to socialize. But I think our division really flourishes when we have a collaborative, inclusive, level playing field, you know, with opportunity and advancement for all. Every year, we really have the privilege of having outstanding Grand Round speakers, and 40% of whom I might add are rock star women. And every year, thanks to Arthi's efforts, we see more and more accomplished women who are recognized national leaders in their field come to speak to us. And Dr. Leslie Cho is one such talented individual, and I'd like to turn things over to Marwa to introduce her.
Thank you, Early. It is my great pleasure to introduce Dr. Leslie Cho, who will be talking to us today about primary prevention of cardiovascular disease in women. Leslie completed her cardiology and interventional and peripheral fellowships at the Cleveland Clinic Foundation, and then served as the Director of Carotid Intervention and Director of Interventional Cardiology Research at Loyola University Medical Center from 2002 to 2005. In 2005, she was recruited back to the Cleveland Clinic, where she serves now as the Director of the Women's Cardiovascular Center. She is a professor of medicine at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University, and is the Associate Program Director of the Cardiology Fellowship at Cleveland Clinic. Leslie is also the Director of the Center for Cardiovascular Disease and Prevention at the Lerner Research Institute, the Section Head of Preventive Cardiology and Rehabilitation, and Chief Quality Officer at Cleveland Clinic. Her clinical research interests include studying heart disease in women and new treatments for hyperlipidemia. She is a co-PI for the Lp(a) Horizon Outcome Trial and has been on the steering committee for international trials of hypercholesterolemia, including the CLEAR Outcomes Trial and the GLADHOPE Trial. I had the honor of working with Leslie when I was a fellow at the Cleveland Clinic, and Leslie was truly a force of nature, a triple threat in medicine with her clinical, education, and investigative roles. And on the wards, we all knew when she was on service in the CCU or on call for intervention, you better be on your A game. And you can see her stilettos behind her there. When we could hear those coming down the hall, we all had to be ready. She demanded nothing less than excellence, and it reflected in everything she did for her patients and the trust they bestowed upon her. And it all came from a place of deep compassion for her patients. She demanded excellence from us in order to deliver excellent care to our patients. She led by example, and we all strove to be as strong a leader, teacher, provider, and investigator as she was and still is, and truly embodied what a strong woman in the field of cardiology could be. She is a champion for the study of cardiovascular disease in women and a pioneer in the field, and we are so excited to welcome her to speak to us about this very important topic today. Thank you, Leslie.
Thank you, Marwa, and thank you, Arti, and the rest of the BI leadership for inviting me to come and speak to you. You know, Marwa was a beloved fellow of ours, and you know, when you get to be my age and you're old, you either become current fellow or graduated fellow, and now you're all in that, you know, that sort of amalgam of former fellows, and she is beloved. We loved her. So thank you so much. And it's really my honor and privilege to be with you this morning to talk to you about primary prevention of cardiovascular disease in women. I'm so honored that I am part of the Women's Development Series, the Women's Staff Development Series, and it's an honor to speak at a Grand Rounds at BI, but more so in the light of the fact that it really focuses on career development from the residents, medical students, to the fellows, to the current staff. So thank you so much. I'm going to talk about primary prevention of cardiovascular disease in women, and you're going to ask me, well, why? Because we know the traditional risk factors, and we all know hypertension, diabetes, hyperlipidemia, family history, and smoking. But there are some of you in the room that's going to be saying, are there really unique risk factors for women? And obviously the answer is yes, because otherwise we'd be done already. So the answer is yes. And I'm going to try to convince you in the next 40 minutes or so about those unique risk factors and why we should be asking those questions and assessing those risk factors for women. So the most important ones, I think, I've listed a couple of them, and we'll talk about how the traditional ones impact gender too, but I really wanted to focus on the unique female-specific risk factors. And the pregnancy-associated cardiovascular disease risk factor is very important and should be part of the question when we ask our patients about risk factors. So adverse pregnancy outcomes, commonly known as APO among the OBGYNs, is hypertensive disorders, preeclampsia, gestational diabetes, preterm delivery or loss, and intrauterine growth retardation during pregnancy. And they occur in about 10 to 20% of all pregnancies, and it's associated with about 1.8 to 4-fold increase in cardiovascular disease. And obviously, the higher risk patients are those with the more severe APOs and with more than one pregnancy associated APOs. So if you had hypertension during pregnancy and you had gestational diabetes, then that obviously increases your risk. It is commonly thought that pregnancy is like a stress test. You have the risk factor cluster, and then obviously, with lifestyle and whatnot, you have overt CAD. But with pregnancy, you have a fast forwarding of sort of what the future may look like. And so because of placental vascular abnormalities, some of these patients end up having, it's just a manifestation of endothelial dysfunction and abnormal cardiomechanics. And then later on, if you don't treat the risk factors, they develop overt CVD. So let's just break it down by different APOs. So this is hypertensive disorders of pregnancy. So we're not even talking about preeclampsia, we're just talking about hypertension. And this is a study looking at hypertension. Some of the studies are looking at the Canadian registries, others sort of look at large sort of HMO studies. But if you have hypertension during pregnancy, you have a twofold increased risk of developing hypertension later on in your life. You have about 1.6-fold increase in developing coronary artery disease, and you have significant increased risk of developing stroke later on in your life. It also increases your risk for having arrhythmias, particularly AFib, CKD, and then obviously it makes sense that they would have heart failure and go on to have aortic stenosis. Now, what about gestational diabetes? Again, these are data from Canadian studies and other sort of large epidemiological studies. If you have patients who had gestational diabetes, majority of them or many of them go on to develop diabetes later on in their life. They also have increased risk for hypertension, coronary artery disease, but the risk for stroke is not as significant. Preterm delivery, this is first child, preterm less than 37 weeks, 40% increase risk of developing CVD. And then with the very, very preterm first delivery, less than 32 weeks, you double the risk. This is also similar if you look at patients who've had pregnancy loss or intrauterine growth retardation. So the American Obstetrics and Gynecology, along with the American College of Cardiology, defines the APOs, hypertensive disorders. Forget preeclampsia, which is what we're all fixated on, but just even gestational hypertension, gestational diabetes, intrauterine growth retardation, preterm birth, placental obstruction, significant amount of weight gain, and maternal age greater than 40 as a risk factor for developing cardiovascular disease. And they recommend that they be screened for cardiovascular disease. Now, this is not to start a 35-year-old or a 30-year-old on medication. This is not about that. This is about assessing risk. Because you now have a patient who has under stress, under pregnancy, shown evidence that they have a significant risk factor for developing cardiovascular disease. We think it's a teachable moment where you can have a patient assess their risk, do a risk profile, and then teach them about diet and risk factor reduction. Now, as you know, majority of women, unfortunately, still do not get their risk factor screening until they hit menopause or until they are in their late 40s. And we continue to sort of fixate on sort of bikini medicine, which is breast and gynecological issues, while ignoring the #1 cause of mortality in women, which is cardiovascular disease. I think, it's a unique opportunity for prevention, not just for the patient, but also for family. And you can really modify their nutrition healthy diet, but also weight control, exercise, and really sort of talk about psychosocial issues, because many of these patients often have difficulty with postpartum. And I think that's an important, a unique sort of teachable moment. But as we all know, and I think, we just passed our Earth Day, it's more than just patient's will. It's the lack of availability for, healthy food sometimes, and the price, the cost of a healthy food, the social cultural norms, the amount of marketing and branding we're inundated with, the time scarcity and the convenience factor. And I think, the lack of knowledge, which we physicians think is the number one problem, I think that's not as important as all the other sort of socioeconomic structural issue that's associated with risk factor modification. And, we often think about risk factors, and we always sort of have this sort of, and I have to be confessional here. I was like this for many years, where I felt like it was patient's will, and it's so much more than just patient's will. And we have to make it easier for patients to modify their risk factor. Premature menopause is also a unique risk factor. Obviously, when estrogen is removed from the body fat redistribution occurs. Obviously, lipids start to increase, higher blood pressure because of endothelial dysfunction, increased sympathetic tone, and then vascular inflammation occurs. And when you look at premature menopause by age, it's really, you have increased risk at early menopause, but it's really the premature menopause, whether you did it naturally or surgically or hormonally because of breast cancer. It's the less than 40-year-old that has significant increased risk for heart disease. But even early menopause, the 40 to 45, there's an increased risk for cardiovascular disease. So the ACC finally recognized the premature menopause, as well as history of pregnancy associated risk factors as ASCVD risk enhancers. So to use that as sort of borderline, in your borderline risk patients, to whether up or down grade patients in terms of risk. I think you will see there are other sort of particular unique female risk factors we'll go through later on, but it is an important risk that we have to be mindful of. So the reproductive history is important for early prevention and treatment for cardiovascular disease, and we think it should be part of every question when you talk about risk factor assessment. Now, PCOS is a well-known risk factor for cardiovascular disease. Obviously, it's a common endocrine disorder that affects young women. It's associated with hirsutism, acne, and hair loss because of hyperandrogenism, ovulatory dysfunction. It's associated with metabolic syndrome, insulin resistance, and there is an endothelial dysfunction and subclinical athero. And if you look at ethnic variation, it's very interesting. East Asian women have highest prevalence despite lowest BMI and less hyperandrogenic features. So it's really important to assess PCOS. International guidelines recommend that all women with PCOS be screened for CVD. And these are people who are young, so even younger patients should be annually checked for blood pressure, fasting lipids, screened for glycemic control, and then assessed for weight changes. And obviously, a good dietary risk factor modification is super important. Metformin is recommended. And then the other sort of important thing that we underestimate, which is psychosocial factors, which is anxiety and depression. It is very prevalent in PCOS and should be taken into consideration. And, as a woman, I grew up in Southern California, where I knew the calorie content of everything I ate by the age of 13, which is horrible. I think it's really important to understand sort of the psychological implication of PCOS and weight for our patient population. Autoimmune disease. Now you're going to look at autoimmune disease and you're going to say like, okay, how is that a gender specific thing? Well, it's 80% of patients with autoimmune disease are women. And if you look at autoimmune disease, it really is a female disease. And it is a risk enhancing factor recognized by the ACCIAHA. It really is important to assess autoimmune disease. And, you know, autoimmune disease is more than just lupus and rheumatoid arthritis. It is any type of autoimmune disease really does increase your risk. Obviously, African-American women are 2 to 4 times more likely to have lupus. They obviously have worse outcomes. It's important to do risk factor modification. Now, we at the Cleveland Clinic, if you get diagnosed with lupus or rheumatoid arthritis, there is an automatic referral to the prevention center and to talk about diet and risk factor modification. Ischemic heart disease is a #1 cause of mortality for lupus. It's particularly a problem in younger women. And it does increase your atherosclerosis, but more importantly, women often have coronary microvessel dysfunction. The other sort of important risk factor, it's more than just having lupus and rheumatoid arthritis, but the duration of time in flare is very important, and it's been linked to increased cardiovascular disease. And obviously that's because of inflammation and whatnot. The interesting lipid paradox is that oftentimes you see patients with elevated ESR and very low levels of LDL. Now, some of that has to do with acute phase reactant and things like that. But we really like to treat these patients aggressively. In fact, we like to keep their LDL it's low. There's some very interesting data about JAK2 inhibitors or JAK inhibitors and lipids in this patient population and how those really increase lipids. But in regards to autoimmune disease patients, we like to keep their LDL less than 70, even for those who do not have established atherosclerosis, because we think it's actually a risk equivalent. It is associated with lowering MACE in this patient population. And obviously, we know that lowering inflammation makes a great difference. If we look at, things like the canakinumab study. So for this patient particular population, we like to keep their LDL less than 70. Now, depression and psychological issues in women, you would think that depression and anxiety is an issue for everyone, and it really is, especially during this time of pandemic. But for women, it has been associated with increase in cardiovascular disease morbidity and mortality, 50% to almost 300%. If you look at depression, PTSD, childhood adversity, its impact, when you look at overall epidemiological study, is no less than the traditional risk factor. So it's equivalent to the traditional risk factor. And I think that makes sense because when you have, we see obviously the extreme spectrum is the broken heart syndrome. But when you look at depression and anxiety, it does lead to poor behavioral outcomes, lack of physical activity, smoking, substance abuse, but also overeating and sometimes making bad choices. And it does increase your cardiovascular risk factor early on in your childhood or adulthood, obesity, hypertension, and type 2 diabetes. It's more common in women than in men, approximately 2-fold more common. Major depression, PTSD, anxiety, all of this is more common. And I think, it's not about just treating women, but it's about treating everyone. And I think as a cardiologist, we often forget about this very important part of our patients' wellness and a sense of well-being. And at the prevention clinic, we do a depression and anxiety screening in all our patients, and we have for years. And we've started in 1993, initially with SF36, and now we've obviously become more contemporary. We use PHQ-9, we use GAT7, we use all these sort of different ways to measure. And if they do have very high scores for depression and anxiety, we have an algorithm and we either send them to a psychologist or psychiatrist, depending on the level of risk, or in certain patients, online therapy. Online therapy was a thing that was very difficult to make patients do, but now with COVID, this is maybe the only positive thing with COVID. The online therapy has become much more acceptable and accepted among patients. So the stressors, the negative emotional stress, there's obviously a resilience factor, but there's also a genetic factor. It does impact the health behavior, the neuroendocrine stress system, which then leads to increased cardiometabolic risk factors, and then of course, cardiovascular disease, morbidity, and mortality. Recognizing it is super important. It can, it can affect your adherence to preventive care. It really should be part of the routine assessment. It really should be part of the routine assessment. It's often confused with physical problems like fatigue and weight loss or weight gain and lack of sleeping, but really it should be assessed and addressed concurrently with the other cardiovascular disease risk. And things like stress management, counseling, support for self-care should be recommended when appropriate. Now, I'm going to spend the rest of the time talking about traditional risk factors, interaction with gender. And the reason I want to spend the rest of the time talking about that is because we often think of them in sort of the same way, but they are very different and in how they impact men and women. So we'll talk about, for hypertension, the age of onset, risk factor for hypertension, blood pressure pattern and medications. And then for diabetes, we'll also talk about onset and then CVD outcomes and how they differ between men and women. So let's first tackle hypertension. So in the 2017 ACCIAHA hypertension guideline, it really provides very little guidance on sex-specific differences in management and treatment of hypertension. And that's the reason why I want to spend some time talking about that. When you look at the NHANES data, the prevalence of hypertension is lower among premenopausal women and then increases after menopause. And so when we think about women who have hypertension, we're really talking about women in their 50s and obviously in their 60s. But when we look at the Nurses' Health Study, looking at over 89,000 healthy women followed for 15 years, and we look at what are the risk factor in women, really it's the weight and diet. That's an important and really critical risk factor for developing hypertension. And I think this is the reason why I think asking about or having an impact after pregnancy and really getting to that teachable moment where you can talk to them about weight, but also about diet, following this low salt diet, it becomes so critical. Salt is, I like to say, a 4-letter word because it's so critical, especially for women in developing high blood pressure. And the pattern of high blood pressure in women is very interesting as well. And this is looking at 24-hour ambulatory blood pressure monitoring. And women, especially postmenopausal women, are more likely to have non-dipping nighttime blood pressure pattern. And as you know, women have very common white coat hypertension. And because of that, I really like to do 24-hour ambulatory blood pressure monitoring. And when you see women, and especially the 24-hour ambulatory blood pressure monitoring and the non-dipping nighttime blood pressure pattern, it's really not that much of a surprise that they would, have cardiovascular events that are related to nighttime non-dipping. So more likely to have stroke and those type of cardiac and also cardiac events in that sort of nighttime. And so it's really important, I think, when you talk to patients, and oftentimes women, when we look at data about compliance, they tend to have more side effect on medicine. I think it's really important to have that shared decision making where you give them data and you say, hey, listen, your blood pressure really doesn't go down at night. That's been associated with stroke and heart attacks. I do think that does move the needle and make women sort of more aware and possibly more compliant on their medication. And I just want to say it's also important because oftentimes it takes more time in our 15-minute slots or 30-minute slots, whatever time you have. These are like long discussions about why you should stay on medicine and why that's important. And oftentimes, we just sort of say, oh, you have white coat hypertension, you're fine, and your blood pressure is fine at home. It's really important that we investigate that white coat hypertension because we know from large studies published in JAMA, I think about a year ago, 2019, that's 2 years ago, that white coat hypertension also is not benign. We know that from therapeutic target wise, this is from the SPRINT study. Oh, I'm sorry, the reference is missing here. When you look at the SPRINT study, which is sad because SPRINT is a hypertension study, it didn't enroll as many women as we liked. But when you look at the SPRINT study, you do see that there is a trend towards better outcome, even for women, when you have intensive control. So it's really, I think, important to talk about therapeutic goals and aggressive. If you're going to treat, you're going to treat aggressively. So mean age of SPRINT, 68 years, but enrolled only 36% of women. One of my goals for the coming year is to really sort of bring to mind how to improve female enrollment in clinical trials. And there's so many issues with that. We'll talk about that during the 9:15 to 10 o'clock session. But the fact that hypertension affects men and women similarly, and yet we only have 36% of women enrolled, is really a shame. Women in SPRINT did have lower cardiovascular disease risk, and perhaps that's the reason why you don't see as dramatic of an impact. But nevertheless, they do have an important important trend towards reduction in cardiovascular disease. So a randomized control study suggests there is no difference in outcomes with antihypertensive medication based on sex. Premenopausal women, you just have to be counseled about the teratogenicity of the RAS inhibitors. Postmenopausal women, I think one of the things we need to sort of think about is the thiazide diuretics may lower the risk of osteoporosis. So when you do have patients who have osteoporosis, that might actually be a good an option. Spironolactone also is a very good option for people who are very difficult to control, especially for our elderly population. Now, I can't leave a hypertension talk without talking about fibromuscular dysplasia. 90% of patients with FMD are women. Of the FMD patients, majority of them have some type of renal artery involvement. The first 1, 2, 3 line of treatment is medical therapy, and in resistant or in patients with renal dysfunction, then it's balloon angioplasty. We like to do IVUS-guided balloon angioplasty at the clinic. And then it affects 40 to 60 years of age. Now, as you know, fibromuscular dysplasia is an important risk factor for coronary artery dissection, which is mainly a female phenomenon as well. Now, let's go on to diabetes. Diabetes, there's a very interesting data that came out of the CDC, which was that if you're a Caucasian girl born in the United States, you have around 30 to 35% risk of developing diabetes. If you are Hispanic or African American, you have a 50% chance of developing diabetes. Diabetes is not just a problem in the US, it's a worldwide problem, but 26 million people in the US have diabetes. Around 13 million women have diabetes. It's interesting that women have higher rates of type 2 diabetes, which is an insulin-resistant obesity metabolic related in youth, and while men have higher prevalence in midlife. The unfortunate thing about diabetes in women is that it eliminates the 10-year gender protection gap. So that women develop heart disease in their 60s, men in their 50s, that 10-year gender protection is eliminated if you have diabetes. And women with type 2 diabetes have 25 to 50% greater risk, excess risk of cardiovascular events compared to men. And they have very different types of cardiovascular events. So this is looking at meta-analysis. This is a 49 studies meta-analysis of 5 million patients. When you look at, these are diabetic patients. When you look at diabetic patients between men and women, women have higher rates of overall mortality. They have higher rates of cardiovascular disease mortality, coronary heart disease. And the important thing about coronary heart disease is that they have significantly increased risk of having heart failure. And it's really important that we prevent diabetes. That's super important. And some of the risk factors for, some of these women are diagnosed during pregnancy. So that's another reason why it's so important. But it's so critically important that once that is diagnosed, that we treat to prevent diabetes, because when they do get diabetes, they have such an increased risk of having poor outcome. Diabetes increases the risk of heart failure in women. This was seen in Stockholm epidemiology study early on, but even in UK Biobank study, almost 500,000 patients, follow up for 9 years. The heart failure incidence is greatly increased. Heart failure mortality is increased. I am an interventional cardiologist. I still do intervention twice a week, but that's really not the answer. We often diagnose patients with diabetes when they come in with non-STEMI or STEMI, and that's really, unfortunately, that's too late at that point. It's really important to be hypervigilant about diagnosing diabetes. There are really no sex-specific efficacy differences between men and women, but I will say this, is that GLP-1 agonists have greater weight loss in women, better glycemic control in men. We all recently saw that amazing study with the GLP-1 agonists and weight reduction in severely overweight patients. And I think women, because they have such a culturally and societal sort of issues regarding weight, I think GLP-1 agonist is a great option in women. TZDs do offer better glycemic control in women. SGLT2 inhibitors are efficacious both in men and women. But I think when you talk about type 2 diabetes treatment, and we really want to do personalized therapy and sort of talk about the efficacy, but also what is sort of important to the patients so that they can stay on medicine. I think it's important to be mindful about some of the differences between these diabetic medications. I could put up the slides for diabetes, hypertension, and hyperlipidemia, and even aspirin therapy as secondary prevention. When we look at diabetic patients, women with diabetes are more likely to be obese, hypertension, and have hyperlipidemia, but they're really less likely to be on lipid-lowering agent or ACE inhibitors, especially those with CAD. But hypertension women are less likely to be at goal. For lipids, they're less likely to be on statins or at goal. I think some of it has to do with side effects. Some of that has to do with our some of that has to do with patients and physicians and sort of very complex issues relating to care. And I think that's the reason why it's so important to have shared decision making, understanding what's important for patients as well as what's important for their outcome, and then sort of meeting them where they are most likely to take medications. And then obviously making these medications affordable and available is important. I am going to, in the interest of time, sort of speed along on the aspirin question for women. As you know, aspirin has come around. We used to be good for everybody. Now it's good for nobody. Recently, there's been Arrive, Ascend, and Aspirin, which Arrive is moderate risk, where you have really no effect on MACE, but increase in bleeding. Ascend is diabetics. You lower the MACE, but you definitely increase bleeding. And then for greater than 70, really negative effect on bleeding and mortality with really neutral effect on MACE. But I want to, and of course this is the meta-analysis, but I want to talk about where it might be useful. I think it's definitely useful in people who have increased risk. And you should really do risk enhancing modifiers. I think there are two groups in which it is very important. One where possibly coronary artery calcium score. If you have a high calcium score, I think that is an important risk factor, important treatment, but also people with elevated lipoprotein A. So lipoprotein A, as Marwa knows, has been something that I have been interested for many, many years. And finally, because we have therapy, we are running a large trial. But in Women's Health Initiative, this is many, many years ago, but in Women's Health Initiative, they actually collected lipoprotein A. And this was a genetically confirmed lipoprotein A, elevated lipoprotein A. And obviously those patients had increased cardiovascular risk, and it was reduced with aspirin. So in patients, especially in women, but I think in men as well, if you have that patient on the borderline, you check their LPA and their LPA is elevated, I think aspirin, if the bleeding risk is acceptable, is a very important therapeutic option. So, of course, aspirin for secondary prevention, obviously. Maybe for people with elevated Lp(a) who are smokers, high calcium score, strong family history, if they're not suboptimally controlled and have low risk. And then no for people who are super healthy with no risk factor, routine use after 70, or higher risk of bleeding. Now, I am just going to quickly finish with the cholesterol management in women. Obviously, blood cholesterol management, you do this. I don't have to tell you this. I think for borderline risk patients, it's important to ask reproductive history, autoimmune disease, check Lp(a). I think calcium artery score is also important, and then share decision making. And then I want to just, again, reiterate that this is a registry of patients. Many women stop taking statins, but horrifyingly, many women were never offered statin. Now, it's horrifying that 13.5% of men were never offered statins, or 6% discontinued statins too, but it's much more likely to happen in women. And so, in conclusion, heart disease is still the #1 cause of mortality for women. There are unique risk factors and treatments that pertain specifically to women. So please ask them. And there is still plenty to be done to close the treatment gap. Thank you so much for your invitation. It's really my pleasure and honor to be with you this morning. And I welcome your questions. Thank you.
Thank you so much, Dr. Cho. That was really fantastic. So for everyone, please feel free to send your questions on the chat or come off of mute. We do have an initial question from Dr. Julia Resti, who notes that African women with peripartum cardiomyopathy are at persistent but reduced risk after moving to the Western world. Do we know to what degree this is related to persistent environmental factors or to genetic factors?
Yeah, that's a great question. I actually don't know what is the risk. Now we know from Asian Americans, we know that, so I don't know about African Americans, but I do know for Asian Americans, and there's been tons of studies in the Hawaiian population as well as in the Californian population. And it turns out that when you have been in the US for a long time, you get all the convenience of the US, including the supermarket. And so your diet and your risk factor tends to be more like the native population with time. I think there is that. I think the problem with the other minority groups, as well as some of the Southeast Asian groups and East Asian groups, has been the socioeconomic factors. I am mindful of the fact that while many people on this meeting can afford a plant-based diet, it is very, very expensive for many of these patient population. And the cheaper food, the more convenient food, where many of our patients live in food deserts, that is an incredibly strong risk factor. I recently have been asked to talk about food deserts and how changing diets from a meat-based to a plant-based can impact the environment. And food makes up 30% of our carbon emission. I know I'm going off topic, but it's really important as a cardiologist to sort of talk to our patients about more plant-based diet. Marwa knows I'm a big proponent of sort of plant-based diet, but I think that's an important thing that we can do for society and for our patients too.
Thank you. Robert Gersten had a comment about Titan gene variants. Rob, did you want to say a few words?
No, only that they contribute to this myopathy that's seen. That was just my point for Jules' question.
Perfect. Okay.
Yeah, so statin intolerance has been linked to a genetic SNP. That study has been done on Zocor, and obviously whether, and it's a little bit different when you look at atorvastatin and rosuvastatin too, but you're absolutely right. There is a genetic component, absolutely, to statin intolerance. But I think that the majority of patients' side effect with statins can sometimes be linked to the fact that they're often on medications that cause interactions. So for cardiologists, it's like amiodarone, diltiazem, Coumadin increases your risk. It's really, it's important to, and it's a risk factor, but it doesn't mean you're going to get it. So even if you have 2 mutations, you still have, you're at an increased risk, but, I don't know.
We have a question from Nancy O'Hare, who is wondering about delayed menopause and the effects on CAD. For instance, women who have menopause in their late 50s or even 60s. Yeah,
that's a great question, and you're right. I mean, majority of those studies were used 50 as the cutoff for average. And there are some studies that talk about delayed menopause, but really not many good studies have been done. But you're absolutely right. I mean, there is some, I think, possible protection from that. You know, there's some epidemiological study looking at population as a whole. Some people believe it's the amount of years. I don't know. So as children go into menarche at a younger age and have a longer duration, you know, that's all sort of an interesting question too.
Great. One more question. I apologize. I can't see the name of the person who's asking this. In your practice, how do you incorporate a history of preeclampsia into the decision to use aspirin for primary prevention, since there is no specific data yet? Thank you.
Yeah, that is a really, really great question. And so the aspirin, I really like to sort of bring up as a sort of a whole person discussion. So let's say it's a 55-year-old woman, she's well controlled, no blood pressure problem, no history of hyperlipidemia, her cholesterol is well controlled, and her only risk factor is preeclampsia, then I don't think aspirin is that beneficial. I think aspirin becomes a talking point when you have people like in their maybe 60s, and then they had, you know, they have high blood pressure, they have, you know, they have high cholesterol, but it's, you know, reasonably well controlled. Their bleeding risk is not great, but they, you know, they did have preeclampsia, and so I think then at that point you can think about talking about aspirin as sort of, you know, as one of the options. I do think when we talk about aspirin, because aspirin was sort of like, you know, thought of as a not harmful. For many years, you know, I would say on rounds, mothers give their baby aspirin. How much could it hurt? I mean, obviously, I'm an idiot because look at, you know, all the bleeding studies. And I think one thing we have to be cognizant of is you do have to weigh the whole patient, the bleeding risk, the stroke risk, and you want to gather, you know, as much data as you can before you talk about, you know, treatment.
Perfect. And that question was from Dr. Anne Maria Nagnostopoulos, which I should have guessed because we've discussed that before. So we have one more question from Dr. Susan McIlvaine. With respect to the worst CVD outcomes in women with diabetes versus men, how much of this do you think is related to undertreatment versus something related to the substrate of these women who develop diabetes?
Oh, that's a really great question. I think that when you look at databases, like, for example, when you look at Intermountain database, looking at their diabetes patients for a long time, when you look at some of the Kaiser databases, women who are well controlled do just as well, I think. But the question is that if you're a woman and you get diabetes at a younger age, because we know, you know, they tend to develop type 2 at a younger age, there is this whole component of PCOS and psychosocial things. And I think you're right. I mean, I think some of that has to do with poor control and all the other socioeconomic milieus that are socio sort of ecological things that are getting in the way of good control. But I think if you do aggressively treat them, I think they do well. Here's the problem with treatment is that the side effect is a big problem. I think the other thing is that oftentimes majority of women are caregivers, so they take care of their elderly parents, they take care of their children. There's all sorts of sort of issues that we really have to be mindful of when we talk about, you know, treatment. It's more than just take your pills and then let's get your hemoglobin A1C down to 6.5. It's, you know, if they're cooking and they have a large family, they don't want to make 2 separate meals. I mean, there's all these sort of issues.
Thank you. I did have a question. I was wondering about the use of coronary calcium in women who have inflammatory disorders and how much evidence there is to support its prognostic value specifically in that population. We do see a lot of young women who have sort of relapsing remitting various inflammatory disorders, including lupus.
So I don't believe in CAC for that because I treat them as if they have CAD equivalent. And I don't know if I'm right or wrong. You know, one of the good things about getting older is you can admit to your lack of knowledge. But I mean, I know there's huge data on people with rheumatoid arthritis and lupus and increased cardiovascular risk. So that's and they have this lipid paradox. So I think that even if in that patient population, their calcium score was 0, I don't know, I don't feel that comfortable. So I do treat them very aggressively. And I understand you don't want to go on medicines, fine. But we want to do everything we can to get you down to as lowest risk as possible. I think that's very important.
Perfect, thank you, that's very helpful.
Can I ask one question as well? Leslie, thank you. That was a fantastic talk. I was wondering, logistically, you described that at Cleveland Clinic, the patients who have these autoimmune disorders are actually automatically sent to the prevention clinic. Is that right? So how does that work exactly? Is it just patients who go to the rheumatology clinic, then they just automatically send them over to your clinic? And you know, how has that been in terms of, because that's a lot of patients.
Yes, that is a lot of patients.
Working?
Yes.
Yeah.
Yeah. So what we do is we like to, so we have taught we have not taught, we have worked together with our rheumatologists to develop a best practice alert. I don't know what you guys have, whether you have Epic or something else, but you can, I don't know how often your best practice alert goes off. If you have a lot of best practice alerts going off, everybody's going to ignore it. So this is not like, but we have worked with our rheumatologists to talk about the increased risk, and they like to send the autoimmune disease patients to prevention. Now, oftentimes we have used our nurse practitioners, our nutritionists, our exercise physiologists as sort of front line. And for their highest risk category, the physicians get involved. So I would see their highest risk category. So for example, I would see their African-American women who have lupus, or their, you know, rheumatoid arthritis patients who are high risk, who are on the borderline. So we like to see them early. And I think that is a continuing discussion. And that trigger has worked out really well for us. We also have a trigger where we see patients who have not just autoimmune disease, but our preeclampsia are high risk. So patients who have preeclampsia, gestational diabetes, hypertension, they get an automatic referral too. Now, that doesn't mean every single patient, because majority of those patients can get the baseline screening with their gynecologist or their OBGYN. And then the ones that are high, like they have an increased risk, they can then be referred. But all of them get, you know, nutrition, counseling, and all that stuff.
Wonderful. Okay, so I think that wraps up our session. It's 9 o'clock. Thank you so much, Dr. Cho. This was incredibly educational, and we all very much enjoyed it.
Thank you guys so much, and I look forward to seeing you at 9:15.
Thanks. Bye, everyone.
Thank you.